Hello and welcome, everyone. My name is Melicia. I am the Program Director for the Georgetown Gender Justice Initiative. We are very excited to share with you our annual signature event, the Georgetown University Gender Justice Initiative Colloquium, which showcases research from all across Georgetown. We have 3 panels for you between today and tomorrow, including 14 presentations that are all examining important intersectional gender justice issues, and we hope that you will learn from it and enjoy all of them. I would like to thank the presenters, as well as my team members and the GJI steering committee, without whom this event wouldn't be possible today. I will now pass it on to our wonderful faculty co-director, Dr. Denise Brennan and Dr. Dionne Coker-Appiah, who will also be moderating the first panel today. Thank you and welcome again.
Welcome, everybody. It's so great to have you join our annual colloquium. This is really our big coming out party every year, and it's a way to showcase the amazing work on gender and racial justice that is happening across our 3 campuses, and sometimes we have folks join us from Qatar. Melicia, we owe you a huge thank you. If everyone can please give Melicia a huge whoop whoop, because this is not a normal circumstance under which to get us all in the right place at the right time. So I just want to fill you in a little bit about the GJI's history. A group of folks across the 3 campuses came together about 5 years ago, and we wanted to build a house. We wanted to build a house for you, to offer support, to offer connection, to offer community, to cook up some activism, and to really make visible all of the work that has been going on at Georgetown. And it's kind of shocking there hasn't been a house. So we're building it, and we need you to continue to help us build it. Send us ideas. If you have a book coming out, you want to do a book talk, we'll throw that party for you. If you want to host a panel, really the sky's the limit. This is your house. So with that, I'm going to turn it over to Dionne, who will moderate, and Melicia and I are going to exit and enjoy the panels. Thank you.
Thank you so much, Denise. Good afternoon, everyone. I'm Dionne Coker-Appiah. I'm an associate professor in the Department of Psychiatry at Georgetown University Medical Center and MedStar Georgetown University Hospital. And I also, as Denise mentioned, currently serve as one of the faculty co-directors for the Gender Justice Initiative. And it is my pleasure to moderate our first panel, which focuses on anti-racism and gender justice in healthcare. We have 4 phenomenal presentations, and I will introduce each speaker and share their bios at the beginning of each presentation. We have allotted 10 minutes for each presentation, and we will hold questions until all of the presentations have been delivered. So please feel free to jot down your questions and add them to the Q&A section of this platform. We will certainly do our best to address as many questions as possible. So we're going to go ahead and get started with our first presentation, which is entitled Integrating a Health Equity Framework for Health Professional Education. And our presenters today will be Dr. Christina Marea and Melicia Escobar. Dr. Christina Marea is an assistant professor in the Department of Advanced Practice Nursing at the Georgetown University School of Nursing and Health Studies and a certified nurse midwife in Washington, D.C. She is a graduate of Georgetown University, Yale University, the University of Bradford, and she received her PhD at Johns Hopkins University, where her research focused on reproductive health of refugee and immigrant populations, gender-based violence, and healthcare provider education strategies to reduce health disparities for vulnerable populations. Our second presenter is Melicia Escobar, who is a clinical faculty director and instructor, also in the Department of Advanced Practice Nursing at the Georgetown University School of Nursing and Health Studies. She is a certified nurse midwife and women's health nurse practitioner in Philadelphia. She is a graduate of Haverford College, the University of Pennsylvania, and is currently a Doctor of Practice nursing student at Georgetown University, where she is evaluating self-efficacy among graduates who participated in the health equity curriculum. Melicia is a 2020-2021 Gender Justice Initiative Fellow, which we're very proud of. So without further ado, I will turn it over to our speakers to deliver their presentation.
Great. Hi, everyone. Thank you for joining us. Thank you for that lovely introduction. So we're going to start off talking about why the health equity curriculum is important. So institutional or structural racism, class oppression, gender discrimination, and exploitation create power and wealth imbalances. And then they in turn undermine social determinants of health, which health professionals then see in clinical practice. So resulting chronic stress, trauma, unhealthy behaviors and cycles that place people further and further away from health and well-being. And biases hinder the ability of health professionals to see intersectional identities and experiences of people in their care, which then compounds and upholds detrimental systems and further reinforces barriers. So incorporating concepts of structural competency, intersectionality, and patient-centered care into health education curricula is a necessary upstream intervention and really investment that may address health equity in the clinical setting. So historically, our curricula was limited to hand skills, pathophysiology, and treatment algorithms. And when we as health professionals are unable or lack the tools to recognize, engage in, and effectively confront the structural or social forces in the care of our patients, we run the risk of missing opportunities for accurate diagnoses and treatment, and can even cause harm. And when care that ignores these forces becomes normative, whether through ignorance, apathy, or lack of resources, there's a certain amount of empathy decline and burnout that takes root and can hinder the ability of clinicians to provide person-centered, appropriate, and effective care. Students and clinicians alike struggle with person-centered skills that often serve as a foundation for meaningful and ethical healthcare encounters. Barriers include lack of knowledge, resources, and anticipated discomfort on the part of clinician and that of the patient when social factors are identified. So in our midwifery and women's health program, from the outset of this initiative at 2015, 2016, we saw this showing up for students, faculty, and clinical preceptors in the following spaces: interpersonal communication and interaction, classroom discussion, in the curriculum itself in terms of pathologizing race, caring for folks living in larger bodies, providing gender affirming care, experiences of moral distress in clinical rotations, including concerns observed in systems, behaviors, and the dynamics that they were seeing.
So in response to the ways our students had been challenged in the clinical environment, in their personal beliefs, and their behaviors, we wanted to take a look at how do we build competency around health equity in our curriculum. So historically, there had been a trend in health professional education of individual responsibility, that each person should become more culturally competent, learn more about the populations they serve, acquire knowledge about them, and that will make them better healthcare providers. Now, we know from experience that that's not actually a particularly effective strategy, that many of the health equities, the structural inequities, the health disparities, and racism really have structural origins. So first, in our curriculum, we want to ensure that our students have a comprehensive framework for understanding what structural racism and structural inequities are, going back to redlining, access to education, housing, different things that contribute to the social determinants of health, and how they are the result of policies over decades and generations, and moving away from a narrative within healthcare of individual responsibility, either on the part of the healthcare provider, that they're going to fix this without addressing and acknowledging the structural environment, or that the patient is individually responsible for all of their risk factors or risk behaviors when they may truly be a result of deep inequities over generations. Then we're also asking, and so in that way we lecture, we provide content and readings to our students so that they have this framework. Then we ask our students to understand how these different identities, Different experiences, historical factors, and current social factors intersect across different levels of identity, race, gender, bodies, sexuality, religion, migration status, language, how all of those things intersect to affect the experiences of health and well-being, and also the experiences of interacting with the healthcare system. We encourage our students to do this through group discussion and personal reflection. And then again, as Melicia mentioned, we focus on patient-centered care, and we do this through accountable behaviors by creating environments where our students do simulated learning, where they have group discussions using a vocabulary around anti-racism and health equity so that they can become accountable healthcare providers, both to their patients, to their peers, and in the academic setting. Next slide. So how are we going to transform the curriculum? Well, our goals begin with our faculty. If we don't have faculty who are confident and competent in addressing these concepts, then it's not going to transmit to our students. They will feel our discomfort. And also, we want to model the self-reflection, the critical engagement with the concepts. We want to revise our curriculum. Now, we began revising our curriculum at the point in which students specialize in midwifery and women's health. And we started it at a single time point to build their vocabulary. We're currently threading it forward through the curriculum so that health equity is touched on in every class, in every discussion of risk factors, in every discussion of understanding what health and well-being is. Then from there, we also want to expand outside of our focus and move into our program and our school, which involves a huge amount of accountability and discussions among other faculty members to say, how have we failed in addressing racism and being an equitable environment? How are we in an ongoing environment that is causing harm? Recognize it, acknowledge it, and also make the commitment to do better as a community for our students, but also for ourselves, acknowledging that promoting health equity is a way to celebrate all humans, to bring us closer to one another, and fundamentally can be an act of joy and love for our fellow humans, along with the Georgetown School of Nursing philosophy of cura personalis, care for the whole person. We can't do that if we don't see them and we don't understand the environment in which they're living. So some of the challenges that we've faced in the implementation of our curriculum is the lack of diversity among our educators. Our program and the School of Nursing and Health Sciences does have a predominance of white faculty members, most of whom are also women. So we're hoping that at a policy and programmatic level, as we increase our faculty, that we take a look at many different types of experiences. We value different forms of knowledge, and we take a look at what are our educators bringing in beyond beyond what historically has been included in our faculty. And this means moving outside of individual networks of who knows who, being more intentional about our recruitment, and the goals for what we want for our program. It involves critical reflection of personal biases, and this is our faculty engaging in conversation with one another and calling one another in areas where we are not addressing our highest expectations. Consistently working to avoid harm to underrepresented students in the process of implementing this curriculum, and addressing the different areas that white supremacy culture affects how we implement any intervention, how we proceed about education, what kind of evaluation we look at, how we think about timelines, implementation, inclusion, and equity. Next slide. So some of the urgent considerations as we're moving towards implementation are to prioritize curriculum development by educators with lived experience, so that we have faculty members, we have gender non-conforming faculty members who are developing that curriculum. We have faculty members who are experts and who have lived experiences of racism, of living in larger bodies, who are teaching rather than someone else who doesn't share that lived experience, trying to develop a curriculum as an other. We want to hear those first person voices. We consider what types of values and knowledge are centered, meaning is lived experience or research, and how do we balance those two narratives when often the most marginalized voices don't have a randomized control trial demonstrating what they know to be true in their lived bodies. And then consider how existing power structures affect underrepresented faculty who are creating and delivering this curriculum. We need to continue to acknowledge the ways our underrepresented faculty may be overburdened in the development and implementation of this curriculum, and do our best as a faculty to continue to support one another so it doesn't become another episode of burnout or taking advantage of different faculty members or community members. One of the ways that we do this in our classrooms is by creating a brave space, moving away from language of safe space that looks to protect those who might be challenged by new conversations, and asking one another to be accountable and to show up, be willing to use our voices, be willing to confront our biases, and continue to show up in a way that is vulnerable and that is willing to learn. So some of the principles of a brave space include speaking your truth, leaning into discomfort and then into one another, committing to non-disclosure, embracing paradox, and seeking intentional learning and not perfection. Some of the areas we've seen our students and our faculty members challenged is the idea that we will reach some sort of competence or achievement or be finished with this project. And so acknowledging the continual nature, having a culture of failing up as we get called in for our mistakes, our errors, committing to doing better, failing better next time, but with this acknowledgement that we'll continue to fall short, but we can continue to aspire to be better. And that we can learn the tolerance for the places where we fail and fall short of one another, and then continue to support one another, call one another in to continue to maintain a brave space among faculty and for our students.
So
We're almost at time. I'm sorry to interrupt.
Oh yeah,
almost at time. Thank you.
No problem. Yeah. So each of these bubbles kind of represents a content area that we address in this introductory health equity curriculum. And throughout each session, faculty highlight the intersectional ways that people may experience each of these and carry them into a given healthcare encounter. And so we do this by using the Jesuit education is kind of like a framing session for the whole curriculum in terms of how to engage in it, grounding in values, preparing to identify and address personal beliefs, biases that may arise, specifically with regard to reproductive health and the role that midwives and WHMPs have in this, as this is heavily politicized in social discourse, but also in clinical environments. Knowing that lack of knowledge, exposure, resources, discomfort, and fear of getting things wrong prevents healthcare professionals from engaging with patients around the social determinants of health and greater structural and systemic forces. Our goal really is to boost self-efficacy in these lower stakes, brave spaces with the hope that students will then have the opportunity to practice this in the clinical setting and in class for further reinforcement and growth. And so what you have here are sources of efficacy expectations that shape self-efficacy when engaging in new behaviors. And in the purple, some examples of techniques to support them that we use in our sessions. And in my DMP work that I'm doing now, I hope to kind of take this next look at evaluating that self-efficacy, as anecdotally our students report that they really value the curriculum and they do apply it in their own clinical practice.
So as we're building self-efficacy within our program, these are the three main approaches that we use as discussed. Lecture, allow people to cognitively integrate new concepts. Guided group discussion to build the confidence to use the terminology, to understand the concepts and the structure in discussion, clarify their own beliefs and articulate them, and then role play. Have an opportunity to practice these skills, practice engaging with the topics before they're in a position to cause harm to a patient. And so this is the development of our curriculum. This is moving forward. I imagine we're at time, so I'll stop here. And thank you very much.
Thank you.
Thank you both for such an excellent and thoughtful presentation that really addresses sort of curriculum revision, reform, and transformation with a specific focus on the structural, intersectional, and patient-centered factors. Such a necessary and timely discussion. Thank you all so much for that excellent talk. Our second presentation is entitled Using Authentic Voices for Interprofessional Medical Nursing Education and Simulation. And our presenters are Dr. Elke Zschaebitz, Dr. Kelly Walker, and Dr. Susan Cheng. Dr. Zschaebitz is an assistant professor in the Department of Advanced Practice Nursing at Georgetown University School of Nursing and Health Studies. She began working closely with the LGBTQIA+ patients and co-founded a grassroots organization in her local community, the Transgender Health Alliance of Central Virginia, addressing the void in medical knowledge in the community about gender-affirming hormone therapy and the complex needs of individuals in transition. Dr. Zschaebitz partners with the Office of Diversity and Inclusion at Georgetown University to address social, health equity, and racial and gender justice issues of the transgender and non-binary communities. Dr. Kelly Walker is an assistant professor and the program director for the nurse, midwifery, and a women's health nurse practitioner at Georgetown University School of Nursing and Health Studies. Her clinical scholarship includes improving maternal-fetal outcomes and access to health care for vulnerable populations. She works within the School of Nursing to address racial equity and social justice issues, specifically on improving access to care for the LGBTQIA+ community, identifying people at risk for postpartum depression, and increasing access to postpartum care. And Dr. Susan Cheng is the Senior Associate Dean for Diversity, Equity, and Inclusion and an Assistant Professor in the Department of Family Medicine at the Georgetown University School of Medicine. She has partnered with the Georgetown School of Nursing to improve education surrounding racial, social justice, and bias training in allied health education. These efforts focus on medical and nursing education and center the needs of the transgender and trans BIPOC communities. Welcome, presenters. You may begin.
Thank you so much. It's such an honor to be here, and we're so happy to have us all together in one room beyond the silos. So I wasn't sure if we needed objectives, but just to recognize the trauma from aggressions and microaggressions from childhood and adolescence for adult, for trans and non-binary patients, as well as BIPOC individuals. Recognizing the lack of healthcare provider knowledge or even phobia when working with a patient with gender dysphoria or gender incongruence. Identifying strategies for inclusive practices when working with transgender non-binary parents in medical nursing education, which is a wonderful segue that we just heard. And they are walking the walk, and we're so honored to be working with them. As well as summarizing evidence-based resources in this presentation and describing the complex care required of this population. So as you may or may not know, transgender and non-binary individuals face bias and discrimination from childhood into adulthood, and they have with limited supports and education across the board about their needs. And so this pervasive social justice issues range from physical safety to murder and violence across the globe, social isolation, rejection from their loved ones, such as family or church members, discrimination from places where to live and even work, as well as their own healthcare aversion and rejection from healthcare providers due to their transphobia. So this means that these individuals have high rates of suicide, high rates of homelessness, sex work, addiction, and exponentially higher in this population, especially in the BIPOC population. And so in order to meet the complex needs of this extremely vulnerable population, we are encouraging the medical, education. And so just moving on to the next. And so Dr. Susan Cheng is going to be addressing this issue.
Thanks, Dr. Zschaebitz. So we wanted to address the gap in our healthcare education. Looking at these headlines, we do a very poor job in providing opportunities for our medical students and our nursing students to engage in the healthcare needs of the LGBTQ population. Speaking about the medical school and schools of medicine, the LGBTQ education that's provided to medical students on probably a median, the median time spent is 5 hours. That was according to one study in 2011. That was updated in 2015 to an estimate of 2 hours of study of this topic in medical education during the 4 years. As a result, not surprisingly, a lot of students feel underprepared to give high quality healthcare to their patients who identify as LGBTQ. 80% of respondents in a survey in 2018 said they felt not competent at all to treat patients from this underrepresented population. It's no I guess surprise that 1 in 5 LGBT adults has avoided medical care because they fear discrimination and bias in their healthcare delivery experiences. So this is where we are woefully underprepared. I wanted to ask Kelly, wanted to shed some more light on the nursing aspect.
Oh, thank you, Dr. Cheng. Nursing as well. The curriculum has been traditionally limited. In a master's advanced practice nursing education, our education bodies have charged us with adding this curriculum in to the content. But with that, we have to think about it again, like medical education. This is not a module that we're adding, and then you have the content and you can move on. What was really important, and being at the beginning of some of this, was to make sure this content is in your pathophysiology courses, and it's in your pharmacology, it's in your ethics courses, it's threaded through. It's not a module. We're not siloing a population of people into 5 hours of content and then you're ready to provide care. So I have the honor of working with Professor Escobar and Dr. Marea and this incredible content that they've developed. And this has made a market change in what we've been able to offer students and how they then give us the feedback that this is impacting their practice.
Thank you so much, Dr. Walker. So we wanted to talk to you about the social injustices that are layered upon healthcare needs. And if you think about it, 5 hours of education, 2 hours of medical education distilled to one of the more complex patient provider needs that are out there. What you're seeing here is when patients come in who identify as LGBT, you see all these layers of social injustices that compound the inequities that our patients face. Black market gender-affirming medications, because medications are expensive and they can't be accessed without Black market. Serious bouts of homelessness, violence and murder that Dr. Zschaebitz talked about. High HIV rates because of sharing and reusing of needles. The necessity of sex work to pay the bills because that is what's needed and required to survive. High rates of suicide, anxiety, and depression, with also substance use and alcoholism to cope with current circumstances. Market isolation. The lack of mentors and resources is only starting to be documented, but a need to support this very vulnerable population. The lack of reimbursement for services and medications is prevalent. And we've only started to speak about the intersectionality of gender and racial discrimination. In particularly the high disparate impacts of healthcare on Black trans women, who are 86% are victims of fatal violence, as estimated by the Human Rights Council. And lastly, bullying in schools. I was just totally shocked to see the statistic that 54% of trans students are often bullied and experience bullying in schools when they go. They will actually walk into their schools feeling like they're going to be hurt and physically harmed. So that is something to note in terms of the social injustices that are layered upon this underserved population. Back to you.
So I think it is important, again, in our prior presentation, why to address this in the education environment, because it allows healthcare providers to start building skills to become allies. Because what we know is that there's avoidance of the healthcare system and of providers. We do not want to be people that continue the damage to the people that we're serving, and they're going to reject the systems. So think about being a healthcare provider and intentional advocacy changes. What can you do when you are practicing in an office, in a healthcare setting, in a hospital? And things that may seem simple are impactful and will create a space where people will feel comfortable accessing care. Make sure your medical records, ask for pronouns, ask appropriate information. Make sure there's dead naming avoidance. Make sure there isn't, you aren't inappropriately approaching language around body. Make sure you're recognizing, validating, supporting, thriving, and celebrating resilience And that can be by what your artwork and what your information is. Again, how you ask people, what are their names? What are their pronouns? These are important things that you can do in your office. Training the staff that you work with, giving them the tools and information that they might not have to help empower them and give them proper information to providing care.
So,
Okay. And so as a provider, our responsibility is not only providing the physical care, but building partnerships and building alliances and getting involved in your community that you serve. And that can be with partnerships with organizations like PFLAG. You can do voluntary mentorship meetings, including students, so we can all learn together. And again, having people represented from the community that you serve. This can be building alliances and partnerships within school systems, some more supporting mentorship, acquiring grants, and doing this across schools. This is a great opportunity that we're not siloed just in the School of Nursing having this discussion, but we're doing this in Georgetown. And having a commitment to curricular change and a paradigm shift, not only in program specific, but across the university commitment.
right. So you can see here, there's a little SACFA.org, and that, so if you're waiting for somebody to start something, probably everybody's so busy that nobody's going to start. So if this is something that speaks to you, you just do it. And so this is how this organization started. And it has no board, there's no structure. We're a bunch of people who get together and we provide mentorship, invite speakers, and we ask each other questions through the email for the day. Hey, do you know somebody who does this? Do you know of a urologist in this area? And so we are able to network really easily. And so it's a really great model. Something, so just the things to think about. We had an Authentic Voice series with Charlie Burton came, and he said recently, he's allowed us to talk about him. You know, he had surgery. So he said, where are you going to put me after the surgery? And they were like, oh, wow, we didn't really think about that. He goes, you can't put me in the OBGYN ward. I'm a dude. And so, you know, and it was interesting that nobody had thought about it prior to surgery or afterwards. So we have to just sort of wrap our heads around changing this complex care and it's to normalize it. It is like learning a foreign language. So he talked about being in the emergency room on a gurney where somebody just came over and just like was pulling on his clothing. And he was like, what are you doing? And he's like, I need to put something on you. And he said, I'm trans. You can't be doing this in the middle with all these people around. And the provider said, so what does that mean? I don't know what that means. So remember that everything's not related to the fact that they're transgender. How can you imagine walking around and having everybody just so focused on some aspect of yourself and nobody's really seeing the whole of you? So that maybe someone's coming in for sinusitis or something like that. So not exactly and nobody really needs to know what their gender, but asking their pronouns is really important.
We're nearly at time.
Thank you.
Great. Well, let's just, we just want to highlight a couple quotes here. Excited to partner with Dr. Zschaebitz, offering these meeting and affirming authentic voice panels of trans patients who really are educating our community about high quality healthcare. So you can see these quotes. I think the main takeaway is they're giving patients a sense of being heard and visibility, and students themselves are learning to develop their confidence with treating patients, and also learning about the humanistic aspects of healthcare. So that's something that's really important. And then next slide, Elke. These are just some of the takeaways that you can read about. In the interest of time, I just want to say that it's important. Language is important, as we talked about earlier with Dr. Walker. And you know, asking questions and being human is super important. Yes.
Yeah. To be continued. We're going to be working on intentional layered sim cases. Hopefully, with everyone who's can provide their expertise and to share our resources with providing cases that can go across School of Nursing and School of Medicine. We can all share a resource together, and also to include those videos of the authentic voices. And so to be continued with research as well. So just again, learning the language. celebrating the leaders in our communities who are happen to be trans, right? Rachel Levine, Kristen Beck from the former Navy SEAL, Danica Rome from Virginia, Philippe Cunningham, the first person on the Minneapolis City Council, as well as Ben Barnes, who's award-winning Stanford neurobiologist. And then everyone has given up their privacy in this slide in order to help others because they were part of the Authentic Trans series. And this was the most important thing to them, was like giving up their privacy to just be themselves and not have everybody look at them. But it was more important for them, for people to know how hard it is for people every single day. So we're going to be leaving our questions at a later time. So thank you very much.
And thank you all very much for sharing your impressive work, and particularly for highlighting the social injustice and intersectional issues that is layered in caring for this vulnerable population. And I particularly enjoyed hearing about the focus on the important role of advocacy, allies, and partnerships in carrying out this work. So thank you all so very much, and we'll look forward to more questions at the end. Moving forward, I apologize for not mentioning this sooner. When I raise my hand, that just signals that you have 1 minute left, just so you know. Our third presentation is entitled In Passing, Elder Care and Expendability in the Era of COVID-19. Our presenter is Dr. Yumi Park, who is the Director of Women's and Gender Studies at Georgetown University. She is the editor of Postcolonial Jane Austen and a special issue of Interventions, International Journal of Postcolonial Studies in U.S. Neo-Imperialism. She is presently completing a monograph, War on Women, Militarism, Gender, and Human Rights, which explores the connections among militarism, human rights discourse, and contemporary theories of biopolitics and sexual violence. Welcome, Dr. Park.
Thank you very much for the kind introduction. And I'd like to thank the Gender Justice Initiative for organizing such a wonderful event. I'll try to be brief and stay within 10 minutes. Today, I would like to talk about what we learned from the last 13 or 14 months or so of difficult times. There are so many painful lessons that we are forced to learn, but for today, I would like to talk about the expendability of the old and the dying. I will specifically talk about what are called the nursing home deaths and what that phenomenon tells us about the reality of our long-term care facilities for the old and the disabled. The discussion will revolve around two themes: the expendability of the dying and those who take care of them, and its gendered, racial, and transnational implications. I am arguing that when the dying and the old are rendered valueless and expendable, the burden of caring for them disproportionately falls on women and the feminized populations, such as migrant workers and workers of color. And both of these aspects are becoming a slowly unfolding crisis right in front of our eyes. If we are willing, it is more than feasible for us to tell the story of COVID-19 around the figure of nursing homes. The first case of the COVID-19 deaths occurred at the Life Care Center of Kirkland, which is located in a Seattle suburb. As the number of cases and deaths skyrocketed around the world and in the United States, nursing home residents and workers have been disproportionately represented in the count of casualties. Here the numbers show only 0.5% of the population, US population, currently live in long-term care facilities, but nursing home residents and workers comprise close to 40% of the COVID-related deaths. In at least, I will not have time to take a look at all the numbers, but in at least 24 states in the United States, a majority of deaths were in nursing homes, 70% in New Hampshire, 67% in Rhode Island, 63% in Minnesota, etc. But our narratives around COVID-19, of course, have not revolved around nursing homes and the consistent predictable pattern of nursing home residents dying at an alarming rate. Instead, we have been mostly upset about the economic devastation and job losses. When Dan Patrick, Lieutenant Governor of Texas, suggested that people over the age of 70 should be willing to give up their lives for the nation's economic recovery, most of us flinched at the unseemliness of his blunt comments, but there wasn't any real discussion about what was really wrong about his suggestion. I'm arguing that these long-term care facilities and the policies that created and regulating are still regulating these policies, these places actually share what Dan Patrick implied, more than implied, the expendability of the very old and the dying, and the lack of value in care labor that the nursing home residents desperately need. Before I move on to the discussion of why elder care has become such a dire crisis in our society, I would like to simply share a few facts as a maybe giving us some glimpse of what the problems here are. The vast majority, around 70% of nursing homes in the US are under for-profit ownership, and especially since the 2000s, private equity firms have purchased many care facilities, and they hope to cut costs and increase profit. So that means much before, even before COVID-19 hit us, our nursing homes had already become a place where the most expendable lives were being managed rather than cared for, while people scrambled to make as much money off them as possible. So how should feminism and feminist thinkers make sense of this situation? The topic of care labor has certainly not been forgotten by feminist scholars. Nancy Fraser has been most insightful and compelling in a discussion of what she calls contradictions of capital and care. She aptly points out that the inherent contradiction between economic production and social reproduction, and how it is a gendered process in which the sphere of production is imagined as a male sphere and women are relegated to the realm of reproduction, which is undervalued, unpaid, or poorly paid. So the understanding is reproduction, that there's a production where basically profit is produced, and there's a reproduction, the realm of reproduction where, for example, labor force is reproduced in a generational sense. The next generation of worker is being born and taken care of, and as well as the daily reproduction of labor. Right, everybody has to go home and be fed and rest a little bit, and then should be able to come back to work. So that kind of a reproduction also needs a lot of labor, but it is not being recognized as value laden or value producing labor. And that is, of course, that has incredible gender implications because women are expected to perform the type of reproductive labor. And I absolutely agree with the Fraser's thesis that the current version of capitalism brutally subjugates reproduction to production, and it has real gender implications. Even so, I still have the feeling that this critique of capitalism and its devaluation of reproductive care labor fit child care much better than elder care. Because we have to ask ourselves, when women quit their jobs and suffer economic consequences to provide elder care, what is really being reproduced? Taking care of elderly patients in their last days does not reproduce labor power and does not reproduce the next generation of citizen workers. Therefore, arguing for the more recognition and compensation for reproductive labor might not be the best strategy for us to learn to value elder care. On the contrary, elder care operates on an entirely different temporality, moving towards the irrevocable ending of any kind of production. How do we learn to value the work that goes into this prolonged process of non-production? And we have to learn to value it. In the last 2 to 3 years, there has been a lot of eye-opening research that told us that elder care, not child care actually, has a larger and more lasting impact on women's career and economic status. And so many of us already know how difficult and even devastating it is. They say about a quarter of women 45 to 64 years old and 1 in 7 women 35 to 44 years old are caring for older relatives already. According to these articles, we don't have time to take a look at these articles, but these articles show that our society's utter disregard for elder care is hitting women especially hard because of its timing. When women start taking care of their parents and elderly relatives in their 40s, the period when their earning potentials approach its peak. It means that given that they're expected to live, these women themselves are expected to live past 80, they have to fend themselves for 40 years or more without sufficient economic resources. And 2, when they themselves need intense care in their older age, they might not be able to afford it. So the articles ask, how will they afford their own care later in life if they can't save for it at midlife while they were caring for someone else? As Nancy Fraser and Linda Gordon taught us in their groundbreaking work on dependency, Those who care for the vulnerable are looked down upon. We're taking a look at the other side of this care labor dynamics. Those who take care of the dying and the very, very old. They are looked down upon and either unpaid or poorly paid, not despite, but because of the care they provide. In our racist society, that means, of course, the task of taking care of the most seriously ill and the dying fall on immigrant workers from around the world. Again, I have a lot of numbers here, but over 1 million workers, or 23.5% in the formal and non-formal long-term care sector were immigrants. In nearly 1 in 3 immigrant healthcare workers were employed in long-term care settings. It's especially horrible with unauthorized, undocumented, immigrants, because unauthorized immigrant healthcare workers are even more disproportionately overrepresented, especially in the long-term care facilities. I'm gonna just skip a couple of slides here. So in our nursing homes, the most vulnerable, old and dying are taken care of by the most desperate and disempowered among us. COVID-19 could be an opportunity for us to open our eyes to this reality and make fundamental changes. But given how casual we have been with what has been unfolding at nursing homes, I'm not too optimistic. We consider the old, sick, and dying as expendable, partly out of fear, partly out of our intellectual and spiritual laziness, but also out of our rational calculation and ideological necessity. So what are those ideological necessities that fuel capitalist systems? Some critics of capitalism point out that, if my computer is not responding. Some critics of capitalism point out that capitalist society and modern medicine do not deem death and fragility part of life, but problems that must be eradicated. Especially in the US setting, it is painfully obvious that the US economy is motivated not to recognize the cost of any type of reproduction of labor force. The Beatrice Muller argues that these two factors form the basis on which guidelines for aging and care practices are formulated. So we go, pretending that we do not get old, sick, and die, and forget the fact that with the help of modern medicine, the process of dying can be unimaginably prolonged. After we are defined as not productive or even reproductive, many of us will go on living. And during that period of our expendable selves, someone has to be there to make that prolonged process even remotely humane. In a sense, it is not at all surprising that the old and the dying in nursing homes have been willingly given up to us by the pandemic. Many of us have been lamenting the fact that we have lost our physical freedom and we are isolated because of the pandemic. However, being isolated and lacking physical mobility were already the living conditions imposed on the most expendable among us. Perhaps that is why we do not really think of those deaths occurring at long-term care facilities as real losses. So where do we go from here? As Joan Toronto points out, care is not a parochial concern of women, a type of secondary moral question, or the work of the least well-off of the society. Care is a central concern of a human life. It is time that we begin to change our political and social institutions to reflect the truth. Having been devastated by COVID-19 for the last 14, 15 months, is it possible for us to remake our society based on the politics of tenderness, which does not turn our fragility and mortality against us, but instead builds and supports a community of equals in which everyone gives and receives care without having to prove how productive we are? Thank you.
Thank you. Thank you so much, Dr. Park, for addressing an issue that is very important yet often overlooked and understudied. And I also appreciate you highlighting the burden of care and the disproportionate impact that it has on specific populations that intersect it across race and genders. Thank you so much. Our fourth and final presentation is entitled The Potential and Promise of MLPs as Anti-Racist Public Health Interventions. Our presenters are Prashasti Bhatnagar, who is a JD MPH candidate, third-year law student at Georgetown University Law Center, and a Sumner Scholar at Johns Hopkins Bloomberg School of Public Health. Prashasti is most passionate about advancing health equity and justice and rebuilding care systems. Some of her research and policy interests include healthcare access, structural interventions, abolition of punitive and harmful systems, medical legal partnerships, and intersection of immigration law and health. Our second presenter is Janae Van Buren, who is a fourth-year MD candidate at Georgetown University School of Medicine. Janae is passionate about health equity and human rights and has interests in medical legal partnerships, structural interventions, and strengthening community partnerships to facilitate equitable access to well-being. She plans to continue her work in these areas where she begins her residency in family medicine at UCLA this summer and throughout her career in medicine. Welcome. You may begin.
Sorry, let me just get this into presentation mode. All right. Can you all see I'm very technologically challenged, but I hope you can hear me and see this. Can you see my screen now?
Yes, we can hear you and see you.
Okay, great. Hi, everyone. Thank you so much for this opportunity. My name is Janae, and I'm joined by my colleague, Prashasti. Prashasti and I recently worked on a perinatal law and well-being project that seeks to use the model of a medical legal partnership, or you may hear us use the term MLPs, to address and alleviate the toxic stress experienced by Black women and pregnant people. So we'll be presenting a framework on how MLPs can be used as an anti-racist public health intervention to address the stark racial disparities in maternal health. Before we dive into our discussion on MLPs and addressing health disparities and inequities, it is critically important to name the foundational role of the legacy of slavery and the longstanding anti-Black racism and white supremacy in creating these disparities. We've already heard this from our panelists before. Any interventions we consider must consider this historical context and present iterations of racism in medicine, law, policy, and socialization. As you can see here, on structural and institutional levels, limits access to birthing centers, hospitals, and essential non-traditional models of care. And we also see interpersonal racism can translate into explicit and implicit bias, which determines how Black women and pregnant people are treated when interacting with the medical system. And it's an important driver of poor quality of care. None of this happens in a vacuum. Not only can these factors lead to acute issues and the far-reaching impacts of racism on multiple levels, which often occur at the same time and compounds over time, contributes to development of chronic disease. The toxic stress levels in Black people as a result of racism has serious health implications. So we see the manifestations of toxic stress on all these levels of racism we just presented, linked to the development of difficult to manage chronic disease and decreased immune response, which you might imagine has implications in pregnancy and beyond. We know that Black women are over 3 times more likely to die from pregnancy-related causes than white women, and Black babies are more than 2 times likely to die in the first year of life compared to white babies. We also see that increased psychological stress during pregnancy is linked to the increased risk of respiratory illnesses and other chronic disease in infants. Understanding a little bit about the direct relationship between social structures in the US and stress leads us to recognize just how urgent attention is required during these perinatal periods if we're going to do anything to address these inequities. In the following slides, we're going to discuss each of these 4 levels of change: legal assistance trainings, practice level changes, and policy level changes, and use this model, the MLP model, and how it can be used to center anti-racism and address the stark racial disparities in maternal health. So now I'll hand it over to my colleague, Prashasti.
Thank you, Janae. As we saw in the pyramid illustration, one of the strengths of the MLP model, especially within the context of perinatal care, is offering legal assistance to address unmet legal needs of Black women and pregnant people. These unmet legal needs, such as housing insecurity, food insecurity, employment discrimination, among others, are conditions that are created as a result of racism. So providing these direct and crucial supports can mitigate the toll of toxic stress in patients and thus contribute to better health outcomes. Next slide. On another level, MLPs also have the built-in infrastructure to build capacity and foster interdisciplinary training, something that we heard a lot in our previous presentations. we have seen consistently that interpersonal acts of racism by healthcare professionals especially are severely damaging to Black women and pregnant people's health, often limiting access to essential care services and contributing to poor health outcomes. Thus, to center anti-racism as a core value, the academic arm of a medical legal partnership can develop anti-racist competencies around the practice of structural competency, trauma-informed care, and the Blackbirding Bill of Rights that are to be incorporated at every step of the professional training for all students and practitioners. So in doing so, we see that the MLP model can be used to help train care professionals to both recognize and address racism, and also invest in reimagining whole person-centered care approaches. On a third level, and these are like happening at the same time, on a third level, working across disciplines also holds potential of facilitating change on institutional or practice levels. So to address the ways in which institutional racism especially harms Black women and pregnant people, MLPs can be used as a tool to help in divesting from racial health inequities and meaningfully integrate social and structural determinants of health into our delivery of care. So for example, attorneys who are a part of the medical legal partnership can provide critical legal support in reviewing and updating internal policies to increase access to care, and interdisciplinary professionals can come together to desegregate the white dominant healthcare workforce and foster safety for patients by expanding access to doulas and midwives, hiring trusted community providers, and removing cisnormative and heteronormative language and thinking from perinatal care experiences. Lastly, MLPs also hold the potential of enacting structural and systemic change by advocating for anti-racist policies. So by virtue of being in an interdisciplinary team, especially lawyers are in a unique position to spot patterns of need for policy change and can advocate for these policies while centering personal stories of patients. Additionally, the academic or the research arm of the MLP already has the resources and infrastructure to facilitate community-led research and recommendations on the impact of racism, something that we also kind of touched upon in previous presentations today, and really focus on structural interventions. In doing so, MLPs can facilitate structural investment into communities of color and address the longstanding impacts of structural racism. So putting all of this together, thinking about the impacts of racism and the model of the MLP, we have seen as research has demonstrated for decades, and even in today's talks, but especially during this pandemic, we know that we cannot effectively address health disparities and inequities without meaningfully and intentionally addressing the role and interplay of racism on all of these levels in creating and exacerbating these disparities. So as we discussed today, MLP kind of gives us that foundation or the framework and the built-in infrastructure to address the impacts of racism on multiple levels and strive to be an anti-racist public health intervention that is really centered on people's experiences and really centered on promoting maternal equity and justice. So those are the slides that we have for you today, and we would welcome any questions that you have in like how to implement these. But both Janae and I were talking about how this fits very well with some of the concepts that we heard today from all of our other panelists, and the need for better training, and then the need of really centering our experiences in caring for the whole person.
Thank you so much. And you actually do have a couple minutes left in your talk, so it would be great if you could maybe just speak briefly about implementation.
Yes, so in terms of implementation, one of the projects that Janae had mentioned too before is the PLAW project, and I'm blanking on the full form of it, but it is a partnership that is an academic MLP with Georgetown. And the idea of using a medical legal partnership is that you kind of are building an interdisciplinary team. So you would have, like this project is at the Washington Hospital Center in their Women's and Infant Services Division. And so they have a medical legal partnership with the research arm being Georgetown's Health Justice Alliance and you have your clinicians or clinic practice at the Washington Hospital Center that has predominantly Black women as patients. And so the idea would be that you are working across disciplines in the ways that we just described, to create that groundwork and those competencies, just so that you're not focusing on, oh, providing direct services, or, oh, like we're just creating curriculum, but how do you do that in a way that integrates it across systems?
Excellent. Thank you so much. And thanks to all of our panelists for such an exciting and excellent and thoughtful discussion around these issues. I see some comments in the chat where people are expressing how much they've learned in such a short period of time about all of your work. All different, all important, all timely, considering what we're going through in this country. And I just really appreciate you all taking the time to engage in this type of work, but also share it with us today. I'm trying to see if we have any specific questions here, and if not, we may have just a couple minutes and we would still have time to get you all to the next panel, to sort of just by way of refreshing everyone's memory. If each group could just share a sentence or two about next steps and how you specifically envision, sorry, my timer just went off. How you specifically envision your work moving racial, gender, and social justice efforts forward, with a particular focus on healthcare and the healthcare system. I know that's a lot, but if you have a sentence or two to sum it up so that our audience will leave knowing exactly what you're doing and where you're going with your work, that would be great. And anyone can just jump in. Or I can call on people too.
I can go. So really our work we see is exponential. So we were talking in our smaller group before we broke out into this larger group, but just about our program. And we are an online hybrid program. So our students are in the community all across the nation, all 50 states, and they come to campus to do skills training with us, the faculty. And one of the reasons the program moved in that direction was to fill these healthcare deserts across the United States. And we're doing just that. Our program is one of the, it's the second largest program in the United States. And we are putting midwives and WHMPs in places where there haven't been, and they're starting practices and they're being leaders in the field. And so by implementing this curriculum here, at this point, we really do look at it, like we said, intervention and investment in health equity downstream, because we're kind of catching people upstream and providing that now with, the idea that they're going to go out and educate. And there was this interesting research I was reading about this kind of second effects. So it was like one long-term study where they looked at kind of the effects of this kind of training kind of ongoing, and there was an effect of in the environment. So there's the person that received the training, but then the people who they work with also had an effect of like doing better and being aware. And so like that kind of exponential value feels really meaningful and hopeful.
Absolutely. Thank you for sharing. Any other thoughts or comments? If not, we can wrap up for today. But if anyone has any burning thoughts about your specific work.
I saw that Professor Graves put a question in the chat box of how can Georgetown better support this. And I think an incredible opportunity right now is that the School of Nursing and School of Health are expanding and growing, and that at Georgetown, we have an incredible health sciences community with medicine, nursing, and other health sciences, but that there's historically been some underinvestment in the academics and research of nursing and health sciences. So I'd love to continue to see more researchers, more tenure track positions, and more integration of the health sciences students with the undergraduates, with the School of Business, with the School of Law, because all of our work is so critically important to move the health of our populations forward.
Thank you all so much. We're going to wrap up now to give everyone time to get to the next panel, which will begin at 4:15. So I hope you all will join us. But thank you all again for your excellent work. We look forward to staying in touch with you and learning more about next steps. And what a beautiful baby there. Learning more about next steps. And we just wish you the best and offer you our support as you continue this important work. Thank you very much.